Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 400 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. The next clinical case reads, PWJ is a 39-year-old, 130 kg, 170 cm tall man who presents with complaints of indigestion. He describes a burning sensation behind his breastbone and some belching that is often associated with an acid taste in the back of his mouth. He indicates that his symptoms began a few months ago, and they only occur a few times a month, especially after eating large or spicy meals. Also, if he eats too close to bedtime, the burning keeps him up at night. He has used liquid antacids in the past for these symptoms and states they work fairly well, but he has to take frequent doses, because the symptoms return quickly. He does not take any other medications. So my first question to you reads, which of PWJ's symptoms are consistent with gastroesophageal reflux disease, abbreviated as GERD? Symptoms that are typically associated with gastroesophageal reflux disease, abbreviated as GERD, include heartburn, pyrosis, that is a retrosternal burning that occurs in the upper esophagus and travels up through the throat, regurgitation of gastric contents into the throat, or in many patients, the presence of both. These symptoms may be episodic or meal-related and are often alleviated by antacids. Heartburn, the most frequent typical symptom, is caused by the contact of acidic refluxate with nerve endings within esophageal mucosa. Other symptoms include water brash, salty or sour fluid occurring abruptly within the mouth, early satiety, belching, hiccups, nausea, and vomiting. Worrisome symptoms, alarm signs or symptoms, include dysphagia, that is, trouble swallowing, adynophagia, that is painful swallowing, vomiting of blood, bloody or tarry stools, unexplained weight loss, and anemia. These symptoms suggest complicated disease, such as erosive esophagitis, esophageal stricture, malignancy, or gastrointestinal bleeding, and require immediate evaluation by a healthcare professional. Some patients, such as the elderly, may not have typical gastroesophageal reflux disease symptoms but present initially with alarm symptoms. This is attributable in part to older patients having a reduced pain perception and a possible reduction in the acidity of the refluxate. Other patients may present with only extraesophageal or atypical symptoms. Despite the lack of esophageal symptoms, the potential for serious esophageal damage exists, because there is no correlation between symptoms and the degree of esophageal injury. PWJ's symptoms of a burning sensation, that is heartburn, regurgitation soon after eating spicy or large meals, and the association of symptoms with eating a meal near his bedtime are all consistent with gastroesophageal reflux disease. The fact that his symptoms are relieved by his use of antacids is also suggestive of gastroesophageal reflux disease. The next question reads, what are the therapeutic goals for the treatment of PWJ's gastroesophageal reflux disease? The therapeutic goals for the management of gastroesophageal reflux disease are to alleviate symptoms, promote esophageal healing, prevent recurrence, provide cost-effective pharmacotherapy, and avoid long-term complications. One long-term consequence is Barrett esophagus, or Barrett metaplasia, which is identified in 10% to 15% of gastroesophageal reflux disease patients on endoscopic evaluation. This premalignant condition may predispose the patient to esophageal adenocarcinoma. Patients with Barrett esophagus have a risk of exhibiting esophageal cancer that is 30 to 40 times higher than patients without this disorder. Gastroesophageal reflux disease is a chronic disease that carries the potential for serious complications. The next question reads, what lifestyle and dietary changes may potentially reduce PWJ's gastroesophageal reflux disease symptoms? Lifestyle and dietary modifications comprise the initial step in managing patients with gastroesophageal reflux disease. Strategies should be discussed with the patient and tailored to his or her specific needs. The paucity of evidence to date suggests that although many patients may benefit from these modifications, they are unlikely to completely alleviate symptoms in most patients. Lifestyle modifications are aimed at reducing acid exposure within the esophagus by increasing lower esophageal sphincter pressure, decreasing intragastric pressure, improving esophageal acid clearance, and avoiding specific agents that irritate the esophageal mucosa. There is evidence to support several modifications that reduce esophageal gastric acid exposure and symptoms. These include raising the head of the bed 6 to 8 inches by using blocks underneath the legs of the bed or using a foam wedge instead of traditional pillows, sleeping in a left lateral decubitus position, and weight loss, which also decreases intragastric pressure. Patients with gastroesophageal reflux disease symptoms should avoid foods and beverages known to trigger symptoms. However, the evidence suggesting benefit remains uncertain. However, individualized lifestyle and dietary modifications should be recommended to all patients with gastroesophageal reflux disease symptoms. When appropriate, over-the-counter or prescription medications should be recommended. PWJ should be counseled to lose weight, wear loose-fitting clothing, and avoid eating spicy meals that he knows will exacerbate his symptoms. Recommend that he avoids eating at least 3 hours before bedtime, as this may help decrease symptoms, and consider raising the head of his bed 6 to 8 inches with wooden blocks. The next question reads, which over-the-counter treatment options, if any, would you recommend for PWJ? Many patients with mild, infrequent symptoms can be managed with over-the-counter medications. First, a determination must be made as to the suitability of the patient for self-treatment. If the patient does not meet the criteria for self-treatment as described subsequently, he or she should be referred for further medical evaluation. It is important to ensure that the following are not present: alarm signs or symptoms, severe or frequent, 2 or more days a week, heartburn lasting greater than 3 months, presence of extraesophageal manifestations or symptoms that persist despite appropriate drug therapy. Over-the-counter antacids and histamine 2 receptor antagonists are the drugs of choice for patients with mild, infrequent heartburn. The non-prescription proton pump inhibitors, e.g. omeprazole, immediate-release omeprazole with sodium bicarbonate, and lansoprazole, should be reserved for patients who experience frequent heartburn. Antacids remain an effective option for treating mild, infrequent heartburn, because they rapidly, that is within minutes, relieve symptoms, but the duration of symptom relief only lasts about 30 minutes when taken on an empty stomach. The duration can be extended for several hours if taken within 1 hour after a meal. Antacids are available in tablet and liquid form and are usually interchangeable when used in recommended dosages. The dose can be repeated every 1 to 2 hours as needed, but the maximum recommended daily dose should not be exceeded. The addition of algonic acid to the antacid may improve symptom relief for some patients. Patients requiring frequent or regular antacid use for more than 2 weeks should be re-evaluated, because an over-the-counter histamine 2 receptor antagonist or proton pump inhibitor may be needed. About 20% of patients will achieve symptom relief with the use of antacids. Antacids are not effective in healing erosive esophagitis. The over-the-counter histamine 2 receptor antagonists are indicated for mild to moderate infrequent gastroesophageal reflux disease symptoms. When compared with antacids, their onset of symptom relief occurs within 30 to 45 minutes, and they have a longer duration of action, up to 10 hours. One benefit of the histamine 2 receptor antagonists is that they can be taken before eating a heavy or spicy meal as prophylaxis for postprandial gastroesophageal reflux disease symptoms. They also have a beneficial effect on reducing nocturnal acid secretion. Tachyphylaxis, that is tolerance, has been reported with continued use of histamine 2 receptor antagonists, but this effect can be overcome with intermittent or as-needed use. Over-the-counter histamine 2 receptor antagonists are available in 1/2 the original prescription low dose and as full prescription doses. Patients should use the lower over-the-counter dose twice daily for mild, intermittent symptoms and the higher dose twice daily for moderate symptoms. The 4 over-the-counter histamine 2 receptor antagonists, e.g. cimetidine, famotidine, ranitidine, nizatidine, are interchangeable when used in recommended dosages. Patients should avoid cimetidine if the potential for a clinically important drug interaction exists with drugs metabolized by the hepatic CYP450 enzyme system. When used for self-treatment, the histamine 2 receptor antagonist dose should not exceed 2 doses per day, and the treatment duration should not exceed 2 weeks. Use beyond 2 weeks should be under the care of a healthcare provider. Esomeprazole, lansoprazole, and omeprazole are proton pump inhibitors available over the counter and are potent inhibitors of gastric acid and are indicated for use in patients with frequent heartburn, 2 or more days a week. The onset of symptom relief is slower, that is 2 to 3 hours, than with histamine 2 receptor antagonists, and complete relief may require up to 4 days after initiating therapy. Proton pump inhibitors are superior to histamine 2 receptor antagonists with regard to symptom relief and duration of acid suppression. Patients should take the over-the-counter proton pump inhibitors 30 to 60 minutes before a meal. Breakfast is preferable, and not take more than 1 dose daily for up to 2 weeks. Another course of therapy should not be taken more than every 4 months unless directed by a healthcare provider, because this may indicate more serious disease. PWJ is an appropriate candidate for self-treatment, because his symptoms are mild and occur infrequently, and he has no alarm symptoms. Although antacids are an acceptable option for PWJ, he has tried these and is unhappy with the frequency of dosing needed to relieve his heartburn. Because PWJ has requested a medication to specifically prevent meal-related symptoms, he should take an histamine 2 receptor antagonists 30 to 60 minutes before eating or drinking. If symptoms remain infrequent but are unrelated to meals, the use of an over-the-counter histamine 2 receptor antagonist as needed for symptoms may be required. He can increase the dose to twice daily if symptom relief is not optimal and may consider an over-the-counter proton pump inhibitor if symptoms occur more than 2 days a week. If he continues to have symptoms beyond 2 weeks, they become more severe, or they are accompanied by alarm symptoms, he should be referred for further evaluation. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 401.